Hello everyone, I'm Dr. Suresh Lidwani, maxillofacial radiologist. Today, on behalf of Oroscan, we will be presenting you a presentation on cone beam computed tomography and its application in day-to-day clinical practice. This presentation has been divided into two parts. One part will be taken by me, in which I will be describing you different applications of CBCT, how to read CBCT, and the other part would be a software demonstration by my colleague Dr. Neelip. So before we start, we need to understand that what role does dental radiology play in our day-to-day clinical practice. Now, dental radiology, whether it includes IOPAs, RVGs, OPGs, and CBCT, it plays a pivotal role in our day-to-day clinical practice. When in doubt about diagnosis, you take an X-ray, you get a diagnosis. When in doubt about the treatment procedure, you take an X-ray, take an CBCT, you get an answer. So it plays a very important role. It's like our Google map for our treatment plan. Like when I want to go somewhere, I will just put up my address and I will get the entire pathway. Similarly, dental radiology plays an important, and CBCT is considered to be a gold standard in this. It provides you an exact path and prevent you to go to the surprise dentistry to more predictable dentistry. But in my brief career of 4 years, I'd get to know that there are misconceptions among many dentists. Some of the dentists use the terminology CT scan, some use CBCT, some use DentaScan. Let me just clarify before we start. DentaScan is just a software which is used in CT scan. And today, we in dentistry are more professionally using CBCT. But what is the basic difference between a CT and a CBCT? In a CT scan, there are multiple slices which are recorded through a scanner and they are compiled to prepare volume. While in CBCT, the entire volume is recorded through a scan and then it can be sliced in the way we want. So there are two basic, this is a basic difference. And another basic difference which we'll discuss right now. But before this, I just want to tell you that there is a difference that piling up a slices into a volume and cutting the volume into a slices that gives a less chances of error in CBCT compared to the CT scan. So as I told you that the entire volume is sliced into a number of slices which we give it to you in our radiology reports. The basic difference between a CT and a CBCT lies in the name. CBCT, as we say, is in cone beam computed tomography. So the beam is in form of cone. So it records the entire volume during its scan, while in CT scan, it records slice by slice and then compile it to a volume. What is another advantage of CBCT over CT? Now in a CBCT, in case you want a small area to be covered, like I just want a premolar to be scanned for my endodontic treatment, then I can go for a sectional CBCT. I can record the small part of that teeth without exposing the other part of the body. But in CT scan, the minimum size in case I want to record a tooth, I need to go for an PNS CT. So the entire face gets scanned. So which I feel is a great amount of exposure. The field of views are basically divided into three: the large, medium, and the sectional. The sectional means could be varies from 4 by 4, 5 by 5, depending upon the company's CBCT you are being using. Now the another big question is that all these things are fine, but still why we already had a technology in CT scan, why CBCT is so widely used in dental practice? And the answer is, you can see the above images are from a CT scan, the below images are from CBCT. Now you can't differentiate between a dentine enamel and pulp in CT scan, but you can very well differentiate between dentine enamel and pulp in a CBCT because of the different exposure parameter, the basic difference. Second is that the small trabecular patterns are well appreciated in a CBCT. So I feel that compared to CT, CBCT plays an important role in a dental practice and justify its presence. Now another big question is, when do we advise CBCT? As I told you, CBCT holds a gold standard. So whenever you are in doubt, you should advise a CBCT. Like a simple example. Now in case we have a panoramic image for one missing teeth. It's quite a simple case. For in most of the our dentists around me, I know, would never even go for a CBCT. They would take a scale and just measure it and do the clinical examination and go for an implant placement. But you never know that this 3D image will always provide you much more detail. You would never know that there would have been three mental foramen in an OPG. So 3D plays a very important role. Now, does it apply only to implants? No, it applies to the every part of the fair dentistry. It is an important role in third molar disinfection, endodontic procedures, periodontics procedure, and orthodontics. We'll go step by step that how it does and plays an important role. But before we start, we should know that how should we read a CBCT? Okay, we advise CBCT, but do we know how to read it? So let's go through one by one. As CBCT, we know it is also called the three-dimensional. When we say three-dimensional, it gives a view in a three direction. One is coronal, which is the front side. Second is sagittal, which is the sides. And third is axial, which is the top view. So it gives a three-dimensional views. Like it is very nicely seen over here. The topmost is an axial view. You can see the buccal side, you can see the lingual side, you can see the mental foramen. Now this view is the best view to assess the canals. Imagine a tooth being assessed from the top. It can show all the foramens and can also shows the canal which are present. In case I want to see the buccal and the lingual cortical plate around my implants, I will go for an axial view. I will view the axial section. Similarly, the right-hand side is called the side view or sagittal views. In case I want to see anything in the mesodistal direction, I would go for the sagittal view. I can see the canal over here. Third one is called coronal view or cross-sectional view. In case I want to see all the four sides of a particular section, the superior, inferior, buccal, lingual, I will go for the coronal views. This is what we generally want to give you in your CBCT reports. We give you an pan image, we give you an axial view, and we give you the slices. So as I told you, the axial view is a top view. It gives you the top view of the particular area. Cross sectionals are the slices from the coronal, from the front side, and panoramic is a single slice of a particular image. Now, this is what I was saying you, that this is how we give you. Now, you can see the entire mandible is divided into multiple slices, which starts from 0 and goes to 150. Similar, the slices and numbers are given in the bottom side of a panoramic image, and the slice is given to each slice. So you can understand this, that entire mandible is cut into number of slices, as I showed you in the bread loaf. It is cut into a number of slices, and each slice is given a dignified number, and that number is marked on the panoramic image, on the axial image, and near the slices, topmost slices. Now, there are two things which you need to understand over here. The one is an interslice distance and other is slice thickness. Now, most of the radiology reports will provide you on the bottom side that what is a slice thickness of this particular report and what is the interslice distance. The interslice distance is means a distance between the one slice and the another slice. Imagine a bread loaf being cut by a knife. If the knife is a thickness of 2 mm, so that the distance between the one slice and the other slice would be of 2 mm. So this is how you need to understand that the interslice distance is 2 mm. Second is the slice thickness. Now the slice thickness is the thickness of that particular slice. So when we are, what role does it play is, now imagine we need to place an implant in the first molar region. Now we are seeing that in the slice number 100, the last part of the premolar is seen. Now, as we know, the distance between the tooth and the implant is 2 mm. Now, in case the interslice distance is 2 mm and slice thickness is 1 mm, so the distance between 100 and 101 would be 2 mm, and 101 and 102 would be another 2 mm. So I will leave those slides, and then from 103 I will decide where I need to place my implants. So this is how interslice distance plays an important role in planning procedure. Why we need to understand is because each slice, when we go from 1 millimeter to another millimeter, the angulation of the mandible changes, the anatomy of the mandible changes, the bone quality changes. So it is necessary to understand for every millimeter by millimeter of mandible or maxilla. Now, once we have decided that how we need to read a CBCT, we thought that we can create a formula to plan in CBCT. So we planned a formula which we call it ABCD, where A stands for bone morphology, B stands for bone angulation and concavity, C stands for communication with a vital structure, D stands for bone density, and finally selection of implants. So A, as I told you, bone morphology. Now the bone structure is different in different area. Now over here, it's in rectangular in shape. This is most frequently found in the mandibular posterior region. The second one is knife edge. This is mostly found in the atrophic ridges in the maxillary anterior region. C is an hourglass. When we say hourglass, it will have concavities on both buccal and the lingual side. So this is the most trickiest one to understand. B, bone angulation and concavity. Now, you know there is in lower anterior region, the bone is slightly lingually inclined. And similarly, in the mandibular posterior region, there is a submandibular gland fossa, which causes a lingual concavity. So you need to understand, you need to analyze if there is any bone angulation or concavity present. Now, C is a communication with a vital structure. The vital structures are present in different areas. Now, let's start goes over quadrant by quadrant. First is between in the anterior maxilla between the two incisors, the incisive foramen and the nasopalatine canal through it. So this is a structure which is present between the two incisors. When you are placing an implant, now most of the time the bone being soft, there is a possibility that we might harm this canal. So we need to understand that we need to stay 2 mm away from any vital structure. Second is maxillary sinus, which is in the maxillary posterior region. Now, maxillary sinus, though being the most forgiving region, is also a most important structure. We all know, as the old age patients with a loss of tooth structure in the early age, the maxillary sinus tries to drip down towards the crest of the alveolar ridge. Now, this phenomena is called pneumatization. Now, this pneumatization is gives us a guidance that whether we need to go for a direct sinus lift or an indirect sinus lift. In case there is a bone remaining up to 4 to 5 mm, we can go for an indirect sinus lift. Less than that can go for a direct sinus lift. Apart from that, there are different structures which are available, which are present in sinus, which we need to consider, like septas. Now, septas are very important procedure during the sinus lift. So you need to make sure to visualize whether the septas are present or not. Apart from that, the posterior to the maxillary sinus is another anatomy called maxillary tuberosity. Earlier, this tuberosity was not given that much importance, but with the development of the immediate loading implants, this maxillary tuberosity plays an important role. Now, there is a vital structure called pteropalatine fossa. Now, this pteropalatine fossa has many vital structures. There is also greater palatine vessels which pass through it. So in case we are hampering those fossa, there are chances of profuse bleeding. So you need to also understand and visualize this anatomy, because now based on the anatomy you will change your inclination of your implant. Sublingual is the most common during the mandibular anterior region. As I told you, though mandibular anterior region is the most forgiving region, there is no much vital structure, but this is a region in which, in case you have not properly maintained the angulation, and there are possibility that it might go into the sublingual fossa and lead to hematoma, which we need to understand. And then the most important and the most compromised one also is an inferior alveolar nerve canal. But why do we need to study the inferior alveolar nerve canal? Now you need to understand this. The inferior alveolar nerve canal present in the mandibular posterior region, though it's a more of pathing in this linear pathway. But now with more and more studies on the CBCT, we have understood that the CBCT, the inferior nerve canal doesn't just path in a linear pathway. Like over here in the first example, in the anterior loop of inferior nerve canal, in this, the canal goes front of the mental foramen and then comes back, and there are many chances there would be an accessory canals also present. So we all need to understand and see the anatomy of the mandibular canal very wisely and very closely, because we never know that when it gets compromised and the patient complains of paresthesia. D. Now D stands for density. Now there is a big confusion that does CBCT gives us an Hounsfield value? No, the CBCT never gives you an Hounsfield value. It gives you a grayscale value. Now, how do we understand that what kind of bone we are dealing with? Now, this is an excellent picture which I want all you to understand this. You just need to remember this four pictures. Now you need to visualize this image radiographically. Now you can see the outer periphery is a cortical bone. It is white. Radiographically, it is the most mineralized bone. So it appears very opaque. Either it will be whitish or grayish. Now, between this, there are trabecular patterns. The trabecular patterns are like nets, like our tennis rackets. And between the rackets, there will be marrow spaces. Marrow spaces are like empty spaces contains of vasculature, so it appears black. Now you can just visualize that when is the more marrow spaces blackish part appear, it will be more on the D3, D4 size. When it is more on the grayish white size with more cortical bone, then it will be D1, and then in between would be D2. So this is how you need to visualize comparing these image with a radiographic image. Now we understood, but with help of technology, now we can think you can analyze more and more with the help of software also. In case some people who are more good with computers can always use the software. It is always an aid to your treatment. Like you can always measure by dents yourself, and also measure the angulations and also the length width according to this. You can always measure the density as I told you, but this is not a Hounsfield value. It gives more of a grayscale value. Though the software will tell you an HU status, but according to the literature, it is a grayscale value. But it gives a good amount of prediction that how the bone is. You can always place the implant virtually, and as you can see, this can also be used as an tool to educate your patient that how and which implant you are going to place and how it would be. You can always go more critical about your implant placement. About after virtually placing the implant, you can measure the amount of bones sparing on the buccal and the lingual side. You can always measure the angulation that on this, that will help you determine that what kind of prosthesis you are will further place it. You can always place an abutment over your implants, so it you need to be more prepared. The software makes you prepare for what would be the outcome of your treatment, so you don't have to, in case you apply, you have to place an customized abutment or an angulated abutment, you will be well determined before the surgery with help of a software. As I told you, there is another, you can use a density graphs which can help you that what would be the density around the implant. You can also measure the amount of sinus lift you need to do. So these all things can be done if you are very little bit good with a computer, you are technically savvy, then this is a very small procedure and also would be covered in the later part of the presentation by Dr. Neil, because it will helps you a lot. Now, apart from implantology, what are the other things which we can do with CBCT? Like the endodontics. Now, endodontics is more common than even implants. So, CBCT is very important in this also. Like we never know the anatomy of any tooth. You can get all kind of detailed anatomical structures visualized in your CBCT. As you know, the axial sections give you the best determination of number of canals, any resorption patterns, any curvatures, anything can be best assumed to be seen in the axial view, any calcification present. Now, always remember that whenever you're going for an endodontic procedure, always go for the smallest FOV, because with the smallest FOV, the voxel size is less and you will get the best image output. Because in CBCT, there is a possibility of any kind of artifacts if there is an restorations or any metal. So in case you are going for a smallest FOV, it will be very good to give a detailed images. Any kind of fractures which are present. Now 2D, though being the superimposition which is present, there is always a possibilities. But with CBCT, you get a definitive answers. In cases of perforation, whether to save, whether to extract, CBCT gives you an answer to it, whether you need to go for an extraction or you need to save the tooth. Impaction. We all know that impacted tooth are present most commonly in 50 to 60% of our adult patients. Now, the big question is, will it come out? Will it need to be extracted? How would be the anatomy? In case we are going to save it, we want to bring it down, how much time it will take? Is there any curvature of the root? Is there any ankylosis present? Is the PDL visible? Everything, each thing is best answered with the help of CBCT. You get a detailed analysis of a relation between the impacted tooth and the any succeeding teeth present over there. So it can be best analyzed on the CBCT. Now, orthodontics. We all know the orthodontics is now moving from 2D to 3D orthodontics. It's no more 2D SEP, it's more of a 3D SEP with a SEP analysis. Now, with an orthodontic procedure coming into the picture, the 2D SEP is no more efficient. The 3D SEP gives you a best value for it. It gives you the best analysis and it gives you the best prediction of an outcome it would give. So CBCT is an boon to an orthodontic procedures. So I will conclude my presentation, and in case you have any query, you can always contact me. Then now the second part of the presentation will be taken by Dr. Neildeep, and I just hand over to Dr. Neildeep. Thank you.
So first of all, I will talk in general for any of the software. So this presentation will lead you to operate any of the software, as well as particularly for Invivo software. So now there is a provided CD or DVD along with the patient. And now whenever you open the CD, you will see this image. It will open within 1 or 2 minutes. So you can see here, there is a 4 images are there. As we have already discussed, that CBCT software comes with the all section, that is an entire volume. So here you can see the axial image, sagittal image, as well as the coronal image. So any software, first you open the CD, this will show you 4 images: axial, sagittal, and coronal. So before starting anything, so I will just go on to the my desired area. So with this cursor, I can just move this cursor and just put it onto the required area. So for example, if I want to see the first premolar for endodontic purpose, you can see in this sagittal section, and this is on axial section, I have kept this cursor on premolar. So now I am focusing this on premolar area. So now you can see the entire anatomy of the canal from coronal to the apex. So we will just move from coronal to the apex. So that will also move in the axial section. So I am just moving it from superior to inferior direction. You can see this is the coronal pulp. Now we have entered into the root pulp, and at the apex, you can see over here that there is a radio opacity, or there is some ledge or calcification of the canal here. The same we can see in this section as well as in the coronal section. You can see that there is a radio opaque calcification is there at the root apex. Now the question is, this is the simple case where there is no or lesser curvature of the canal. In such case, when there is a curvature of the canal, we can simply move the tooth canal or move the entire image according to our requirement. For that, we need to select this reorientation. So now, pressing on that reorientation, I can simply move the canal part according to my requirement. So now, this is on the alignment of the section. For example, our arch is not always in the X and Y plane. So if I just want to move this section, so I will just move this to orient it according to my requirement. So that will give me almost three-dimensional idea, which is not which we are not able to see in two-dimensional image. So this is very useful in endodontic purposes. So this will help us to guide in accessory canals as well as root fracture as well as minute fractures which are not able to visualized on two-dimensional images like IOPA and OPG. So now, if this kind of image comes to me, that might be confusing for me, as well as I may not be familiar to this kind of image, because I know as a dentist we all of are familiar to the images like OPG or IOPA. So for my suggestion, it is better that we first see the pen image and then do the eventual sectioning. So now we are moving on to the second part, that is arch section. Invivo dental software shows this as a art section. Many other software suggest it as a super pano, panoramic pan image, as well as super curve. So now we are moving on to the art section. You can see here there is a entire mandibular arch. So that I have already formed. But if I want to reform an arch or just to check it, I can select this area. Here you can see this is a formation of new arch. So I'm just selecting the new arch. So just by clicking this area, you can see I am forming an arch because there are variation in individual jaw. So I'm just selecting the entire arch. So now we are able to see the pen image over here. So now I am familiar with the pen image, of course, and here I can see there is a now marking. So now in this pen image, we can see two things, that there are edentulous area on the both sides. Both sides 3/7 and 4/7 are missing. So now, for example, if I want to place an implant in this area, so now the number or numerical value which is shown in this pen image plays a very important role. For example, my implant site is this. So I have to check the section between 40 to 50 or 55. This is my implant site. So now I will check for the section. So for that, I can change my layout so I can see the further more and more sections. So layout can be changed according to our requirement. So I'm just changing it. For example, now I just want to check the superior inferior dimension as well as buccolingual dimension to select the implant size. So I'm just moving my cursor or this green line to the desired area. You can see when I am moving this line, so this line also moving in the axial section also. So now I will just keep it near to the my desired area. So my implant placement site may be somewhere near 40 to 50. So here I am selecting almost the center point, that is somewhere near 48 to 50. So just by double click, I can zoom the image. Now this is my desired area. So I just want to check its dimension or available bone morphology from superior to inferior direction as well as buccolingual direction. So I'm just using the tool, that is distance measurement tool. You can see over here it is written distance measurement tool. So now I'm measuring this. So now I have sufficient amount of bone, that is 10.25 millimeter in buccolingual direction, as well as I have sufficient amount of bone from the sufficient amount of distance from the inferior alveolar canal, that is 12.92 mm. So this gives me an idea about the size and site of implant selection. Apart from this, what I can do is I'm just changing the layout so we can see the zoom image. Now, as in previous session, Dr. Suresh has discussed, there are chances of sublingual undercuts are there. So here we can see there are sublingual undercuts. In spite of having an sufficient amount of bone, there are chances that while drilling, we may pierce or we may perforate the lingual cortical bone. So now, here we need to change the angulation of our implant. So how to change an angulation of implant, or how to measure the angulation? So here we have another angulation measurement tool. So with this, we can simply measure the angulation. So this is the x-axis, and the amount of implant is the x-axis parallel, and then the amount of implant or the amount of tilt I need to place according to the anatomy of the ridge. So now I would like to place an now, apart from angulation of implant as well as measurement, we can also check for the bone density. So if this is my desired area, so I can check with the bone density in this section. This we just need to select this HU. HU means Hounsfield unit of city. So now we just need to select this tool, and then we need to select our desired area. So I'm just placing this. So now this gives me an idea about the grayscale value as well as Hounsfield unit. So now you can see in this area there is average of 903 Hounsfield unit. Let me tell you, Hounsfield unit suggests the density of bone of city. For example, -1000 is for air, and plus 1500 to 2000, that is for most dense part of our body, that is enamel and cortical bone. So now even I have selected the cortical part, that's why it shows the maximum values, as well as it shows some part of marrow spaces also. So if I just select the marrow space, it will show me the less amount of density. I'm not including the cortical part. So you can see the average part is 536 Hounsfield unit. So now this way, this software will help us to detect the pre-implant assessment, for example, dimension, angulation, Hounsfield unit, everything. Now I would like to check this. So now Cbct software is also useful for uh, disinfection or impacted teeth, as we have discussed. Now in this section you can see there are two impacted molars are there. So now we can see the distance of impacted third molar root from the inferior alveolar canal, that can be easily measured. So I am just moving my cursor onto the root area. Now this is the root area. So here we can see the root portion is somewhere near here, and it is quite at the distance from the inferior alveolar canal. We can even measure this distance. Another important part is here it suggests that root of the impacted forehead is nearer to the lingual cortex. This is the buccal cortex, this is the lingual cortex. So we can see our approach might be, or the extraction might be easier if we approach from the lingual aspect, which is very difficult to see in conventional 2D radiography. So this is the small presentation of a basic software um, understanding. So now these things can be used for any software apart from this also. So here I'm ending my presentation. So if you would have any question, queries, or if you want me to repeat anything or explain it anything in detail, I would like to hear it from you. Thank you.